Right, just to let you know that all the meetings are recorded, also live on YouTube. Please turn phones on silent and make sure your microphones are on. Also, language use is appropriate to this setting. Okay, apologies for absence.
Yes, Chair. Apologies received from Councillor Heneath and Councillor Cook and co-opted member Mr Griffiths.
Just to say that we are sending recovery warm wishes to Mohammed Hanif and wishing him well on his road to recovery, if that can be noted.
Can I just add, Councillor Clinton, he has a flu, so he said if he can, he will join us online. So if not, accept his apology.
Okay. To report any appointment of any substitute members serving for this meeting of the committee.
Yes, Chair. We've got Councillor Denning substituting for Councillor Heneath.
Hanif, okay. To receive any declarations of interest under the Members' Code of Conduct.
Yes, I'd just like it on record that I'm an employee of the Dudley Group of Hospitals.
To confirm and sign the minutes of the Health and Select Committee. Do apologise, sorry.
I'm a patient safety partner at Dudley Group NHS.
Okay, noted.
Yeah, me too.
Okay. Carl Denning. And
Thanks, Chair. I tried to resist the urge because I'm convinced we don't have to do this every meeting, but I declare an interest as an employee of West Midlands Ambulance.
okay, noted. To confirm and sign the minutes of the Health Select Committee held on the 31st of July 2024. Pages 4 to 15. Okay.
Chair, am I okay to just raise a question in response to one of the points made, if that's okay?
Okay.
So at the last meeting, I raised a question about green social prescribing, and the response was great. I'm really glad that it's happening in the Dudley Borough. But one report that I read last month raised the fact that prevention is better than cure. It was the Darcy report commissioned by the incumbent government, actually, and what that said in the report is prevention is better than cure. Interventions that protect health tend to be far less costly than dealing with the consequences of illness. And I wondered, as a result of this report, whether green social prescribing was something that in the Dudley Borough we could really look into expanding, because I think we live in a very highly built up area, and there's actually quite a few really good natural spaces on our doorstep which we could make a lot more use of. And I know that in my ward in Lyons Stourbridge North, the community have really benefited from things like community walks. But there's also multiple other opportunities that we can use on green spaces as well. And I just wanted to pose the question, is this something we could really look into expanding on?
Medea?
Yeah, absolutely. Social prescribing is commissioned by the NHS. There are two, there is a central team, and that's provided by DCVS, okay? And then each PCN, primary care network, has their own social prescribing team. But absolutely, I do agree, as part of that Darcy report and the direction towards prevention, we can work in collaboration with the NHS colleagues to maximize the use and the effectiveness of social prescribing. Thank you. It's taken. Yeah.
Okay. I would like everybody to introduce themselves, please, so we can all get an idea of who is who. And obviously, I'm Councillor standing in for Mohammed Hanif, Councillor Caroline Reid.
Amayada Wafan, Director of Public Health.
Councillor Cole Denning, Castle and Fiver.
Neil Buckton, Dudley Managing Director for the Black Country ICB.
Daniel King, Head of Primary Care at Dudley Group.
I'm Jenny Kale. I'm Deputy Director of Ops at Dudley Group.
Hello there, I'm Kat Rose. I'm Chief Integration Officer at Dudley Group.
Councillor Karen Westwood, Brockmore and Pensnet Ward.
Councillor Ellen Cobb, Lyons, Stourbridge North.
Councillor Adam Aston, I'm the Shadow Cabinet Member for Public Health and Adult Social Care.
Councillor Sandal for Sedgley. Councillor Kettle, Penmore, Stourbridge East.
Councillor Peter Dobb, Pell Vale.
Councillor Bex Collins, Haley Green and Craigiestown.
Thank you. On the screen, sorry. Think you're on mute.
Pete Lee for Amblecote Ward. I'm sorry I can't be in person with you tonight, but I'm just coming out of COVID.
Okay, noted. Right. Anybody from the public? No, just in case somebody might be hiding. Right. Update on High Oak surgeries, pages 16 to 18, please.
Thank you. So I'm here to present the report. So just for background, these High Oak surgery did transfer to Dudley Group as of the 1st of October. So this is day 3 of this surgery sitting under our remit, but we've got colleagues that have also transferred with us. But in terms of an update, I'm aware that obviously the consultation and engagement has previously happened, but what we action, and I'm pleased to say, is we have worked with Galleria Pharmacy, the developer, for an appropriate business case, which was submitted to the Integrated Care Board for review to discuss and consider through their governance process. It was submitted just before DIHC ended, before it transferred to Dudley Group. So we'll be working with the ICB on that business case to move it forward through the governance and receive what feedback they've got on that moving forward. And we hope that we would have a further update in December.
Anyone got any questions?
Yes, what I'd like to say is Brockmore and Pensnet is my ward. Regular discussions with our constituents suggest that a state-of-the-art facility is still what is required and needed in Pensnet. My first question would be, could you inform us what's included in the business case, and could you outline the full range of services that will be provided?
Do you want to take that, Jenny?
Okay, so the business case is actually the pharmacy's business case. We as Dudley Group are supportive of locating our GP service that we're providing for Pensnet into that. In terms of the wider services that go into that, that's a discussion that you'll need to have with the pharmacist, because they're obviously the lead for that development.
And just as a follow-up, obviously your support is welcome and appreciated by myself and my 2 colleagues in Brockmore and Pensnet. And what another question I'd like to forward is what support the council offer to is the council offering to ensure that this facility is up and running as soon as possible, following their commitment 2 years ago to bring this about.
As you are aware, Councillor Westwood, we are working for a community. We are leading on a community improvement in Pensnet and Brockmore. As we stated, this is one of the most deprived wards in the borough. Having the surgery is important, but it's not going to solve the problem of the ward. This is why we are We've done engagement and we are prioritizing childhood obesity. And we're working now, we have a researcher who's going to be continuously engaging with the community, and the plan is to identify community leaders to start to lead on a social prescribing model. Okay, in that, and we are hoping to link with Dudley Group and utilize their experience and being a large organization in supporting that. But as a council, we don't have a say in commissioning primary care or hold the budget into that. Our role is just to facilitate, and probably the aim is to have a community embedded primary care.
Thanks, Chair. I know this issue has been bubbling away for quite some considerable time, and so I'm a reasonably newcomer to this particular issue of High Oak. Just a quick question, and it's regarding point 10 on page 17, and relates to the car park, which I understand is next to the location, and is being proposed for disposal by the council, which seems a bit odd that potentially we're going to end up in a position where, with this new facility, but that the land which potentially would be used for parking is going to be sold off by the council. So my question is there any pressure that the Public Health Directorate can put onto corporate landlord services to prevent that from happening, or to at least put that on hold until the business case process has been done and concluded? Thanks, Chair.
I'm happy to try, Councillor Aston. I'll give it my best shot. Can't promise, but I'll give it my best shot. Yeah.
Thank you, Councillor Reid. In response to your query, Councillor Aston, we found during the consultation period that actually people's concerns were that they were having to find means of transport to go over to Burley Hill. So I don't think that car ownership is really too much of an issue here, because people do tend to walk from Pensnet Village up to the surgery, at least when it was situated there. I'm just going to make an observation. Point 13 on page 17 says about finance and how the costs for the scheme are commercially sensitive, so cannot be disclosed. I'm a little bit concerned that we as members are actually scrutinising this process, and it would be my absolute worst nightmare, having been in this process since I was elected as a councillor into Brockmore and Pensnet, and I'm now in a different ward and this is still rumbling on. It's just a shame actually that this information isn't given to us as members, because my worst nightmare would actually be for the ICB to say that it is too expensive for this to happen and nothing be put in place in terms of this facility because of cost implications. That's just my observation there. For the author of the report, I don't very often pick people's reports apart, but point 17 on page 18, it says, we know the area has high health inequalities and some. That would be a pretty big understatement, because the reception and the feedback that me and my colleagues at the time were getting when this process first started getting underway is that a lot, so I'd say many rather than some, patients reported that they were negatively impacted just on observation, because it seems to be that the impact on these residents are being minimised. Thank you.
So in terms of the first point about the costs, they aren't our costs to share. Obviously, it's been produced by a developer and Galleria. I think what I would say is we will work with the ICB. I think the commitment is there to look at what we can provide in Pensnet and work with it. If it was, we would look at see what other alternative options there could be in terms of other locations. And as I've just taken on this scheme with Dudley Group, we can have a discussion try and think of what a plan B might be if that was. So happy to take that as a point moving forward. Now that DIHE has joined Dudley Group, there's probably other options of the PensNet and how we can support that. So I'll take that forward in terms of that. And in terms of the point about we'll reflect that in future and make sure we put the actual data that was collected in terms of the feedback rather than a generic statement.
Anybody else? Councillor Westwood?
Yeah, just one final point regarding some patients. There was a community petition done in 2021 and there were many hundreds of people that signed that. So I would agree with Councillor Collins there. It's far more than some patients in Brockmer and Pensnet. Thank you.
Noted. We'll take that. We'll put the actual data that we've collected.
Okay. Item 7 on the agenda, all age mental health needs assessments, page 19 to 22. There.
Thank you. Thanks, Chair. As some of you were here in March, University of Wolverhampton presented the overview of the needs assessment. They have been commissioned to undertake the needs assessment, all age needs assessment, and a system-wide project for Dudley. So this is a progress report just for members to note the progress and the timeline. Just a reminder, the objective or the purpose of the needs assessment is to look at the mental health and mental ill health problem in Dudley, to look at the literature and examples of good practice in terms of how we can improve mental health in an area like Dudley. And also they will speak with stakeholders and providers, and they will speak with people with lived experience around mental health. When it came in March, there was a suggestion from this committee also to include looked after children, and they have done that. So there are 5 stages of the needs assessment, which is looking at the data in Dudley, and I think one of the added value is having a appraisal of the data, because we don't know. We in public health hold some data, the mental health trust hold other, and there are national data. So they will appraise and tell us, give us a view of what is available there. And also, as I mentioned, they will look at the literature and they will ask stakeholders. And then the final stage is focus groups with community and lived-in experience. So the 3 stages they have finished, and now the only left stage is the focus groups. And as I mentioned, in addition to the looked after, they will look at school-age children with anxiety and absence from school, and a specific focus on SEND, and also working age adults with long-term illnesses and who are out of work. So this is what is left. The expected output and outcome, they will be a public-facing summary report, and then we will have the full technical report with all the detailed analysis and data that will be for our internal use in public health. We expect to receive the final report in November. So next month, by the end of next month, the project will conclude. We will use that project to inform a system-wide mental health strategy. And that strategy will have a strong focus on mental well-being and prevention, in addition to sorting out pathways and waiting lists for children and camps, and coming with, not sorting out, but coming with recommendation on how to improve the mental health well-being. I see the strategy, the vision for a strategy is 2 pathways. One pathway is how we, as a population, maintain our mental well-being and emotional resilience from 0 until end of life across the life course approach. And then the second pathway, when people are unwell, how they can access the services that is culturally appropriate, that is accessible without long waiting lists. So that is the vision for the strategy. I'm happy to answer any questions.
Are we on track to complete though at the end of November? We are.
Yeah, we just met with them, I think, earlier this week on Monday, and we got a preview of the completed sections. Yeah, we are on track. They're really good. And it's a whole team working. It's a community department of Wolverhampton. It went through a proper commissioning procurement process, and they won that contract. Yeah.
Open to questions. Okay.
This is just in regards to point 6 about the community research aspect. One thing that's come up quite recently is how difficult it is for parents with SEND children to get a diagnosis. And that's quite concerning, like they're waiting several years and this is really impacting their education. And I just wondered, like, would the research include these cases, and also how do you intend to go about gaining a more in-depth knowledge on this subject, really? What methods are you using?
So we've just concluded a needs assessment on speech and language, which is really majority of waiting lists now on CAMHS are autism due to speech and language. So I'm happy to share the needs assessment with you. It hasn't been ratified yet, but it will be taken to the Children and Young People Board, and it does have recommendations on how we can speed up and identifying and diagnosing children, because the earlier the diagnosis and intervention, the better the outcome for a child. If he or she are diagnosed by the age, around the age of 1, and then they receive the appropriate interventions, by the age of 3, they will be normal in terms of in the lower and mid spectrum of autism. Okay, so there is a merit of early diagnosis and intervention, but to answer your question, the needs assessment will not cover that because we've done that in a separate project. Yeah.
Anybody else? Councillor Aston.
Thanks, Chair. Just following on from that, point 6 on page 20, just out of interest really, regarding the practicalities around engaging with working age adults suffering anxiety, long-term illnesses who are not in employment. I suppose how do the researchers identify those people, particularly if they're not in employment? How do they know who to go to, if you understand my question?
That's a good question, because part of the steering group who are supporting this work is a Black Country Mental Health Trust, so they will help in identifying those patients. My team is well connected with the SEND, my children team with the SEND team, so we are supporting the provider to reach out to those children.
Okay.
Have we got a average time frame for the EHCP or SEN evaluation on the educational psychiatrists in the borough?
There is a transformation subgroup working on the transition of SEND from children to adults. So we are working on that, but we are not really working on the psychology. The public health space some towards the psychology service. We are reviewing that, but with a view to maximize cost effectiveness. I'm not projecting or suggesting to remove the fund, but making sure the fund can extend to a more services.
So we haven't got a time frame for children in need of EHCP or SEN, so they can actually be not disadvantaged in the classroom. Because from my findings, there's almost 17 educational psychiatrists employed by the borough at the moment, and the amount of EHCPs and SENs that are coming through are very, very small.
Neil, do you want to answer this?
Yeah, I don't know if I don't know if I'm answering the question, but we do monitor the timeliness of the production of EHCPs on a monthly basis, and I'm sure the Director of Children's Services should be able to provide you with that information on what the current performance is, or Sue Powell in Children's Services. And it has improved, but there are peaks and troughs in terms of the number of requests for EHCPs that presents a bit of a challenge. But we've got quite a lot of data that shows both our local performance, how we perform in relation to the rest of the Black Country, and how we compare with the kind of England average. So I think Karen should be able to make that sort of information available. Chair, yeah.
Yeah, I'll request that. Thank you.
Anybody else? Okay, we'll move on to agenda 8, Public Health and Wellbeing Directive Plan 2024 to 2025, Q1 Performance Report, 1st of April 2024 to 30th of June 2024, pages 23 to 45.
Thank you. Thanks, Chair. Just to highlight, we are working to add more KPIs. So the current KPIs do not reflect the whole work of the department. So in the next, in Q2, you will have a longer list of KPIs. The reason we needed time because there are we are mostly commissioner of services. So very few services we have direct control of. So this is why we needed to agree those KPIs with providers as well. If you see in this, there are 6 KPIs and all of them are above target. I've also included our business plan, which the new KPIs will be based on those business plan. There are around 35 objectives in this business plan, and there are 36. 35 of them are on target. One that is not on target, and that is food inspection of new premises. The reason for that, and this is not just for Dudley, in the whole country, we are as a food team inundated with requests for inspection from new restaurants and other food businesses. So we've really a long backlog, and we commissioned a private provider to do the inspection so we can clear the backlog. So that is the reason why it is not on target. So happy to answer any question.
Open to questions. Okay, Councillor Denny.
Yeah. So how many direct employers has Dudley got for doing the inspections? Have we got any at all now, or has it all been advertised?
It is commissioned out just to clear the backlog, but I have a food staff. I don't know how many whole-time equivalent. I can send you that.
But it's not just food premises that they inspect. It's actually pubs, breweries.
Yeah.
You know, if we're going to actually do well in the borough, we need new businesses, and they need the licenses fast. Can't wait 3 months for a brewery to actually get a public health license, because they'll just go to another borough
So no, the license is not conditioned to an inspection. So they can open and get the license without being inspected. The danger of that is if they are not following the requirement and an outbreak, or so it's around protecting the public and ensuring that their cleanliness and everything it is in line with the requirement. So they're already opened and they are working and doing businesses.
And then one final question, Chair, sorry. So you've got the Dudley Empowerment Partnership.
Yeah.
That are actually on target, according to it, for the contract management new proposed plan about long-term health conditions.
Yeah.
How are we measuring that?
We give them a target, so it is the we call it self-management program. So anyone can refer primary care and they accept self-referral. So we give them target in the contract and we monitor that. The course is 6 weeks course to enable people, and it's run by volunteers to enable people to cope with their long-term conditions. There are courses that is generic for all long-term conditions. There are specific courses, one for dementia or carers and others. So, as I said, there are targets in the contract and we monitor those targets.
Because obviously the report just says you're on target.
Yeah.
We haven't got any data to actually measure. I mean, on that, most of these are saying on target, which is great. But problem is, if everything's on target, are we actually challenging all of these organisations to actually do more, to be better for Dudley, to actually be better for the people of Dudley? You know, actually outreaching that bit more. I'm not saying I want them to fail, but equally, when you only see on target or completed, it don't seem like we've actually challenged them enough.
As I said, we will have a numerical KPIs, which is based on numbers next, because we are negotiating and developing, just deciding which ones, because we've got hundreds of KPIs. So we're going to choose the ones which will show the progress. Yeah.
Councillor Aston.
Thanks, Chair. Couple of questions just regard on page 24, paragraph 6, which includes the table for the reporting period of April to June. Just regarding those 5 KPIs that have been smashed, I suppose my question is a bit following on from Councillor Dennings. Are the KPIs ambitious enough if we're doing so well at them all? And specifically regarding PI 2257 and the value of savings made by prevention to people of the scams team, I suppose my question is, it's notoriously difficult to estimate how much has been saved because by definition it's prevention work. I suppose my question is, how do we arrive at that estimate of savings of 244,000 and what's that based on, and how do we know we've done that well compared to the target, if that makes sense?
Yeah, it does make sense, and thank you. The majority of those targets are national targets. For example, smoking during pregnancy, by the time of pregnancy, and those things, which is 9.5. So these are nationally set target. In terms of the saving of the scam team, there is like a formula, and then they get into how many boxes of whatever they quote, and then they calculate the savings. So it's a national formula used to calculate the savings.
Just following on, so that means we can benchmark ourselves against other local authorities, and we're not. Okay,
we're one of the very few local authorities who we have a very good working scam team.
Fantastic.
I would say, yeah.
Marvelous. Thank you very much.
I think we will benchmark positively, yes.
Absolutely. Brilliant. Thank you very much.
Right, I have a question on page 28. Build on work to improve the oral health of children in Dudley, particularly those living in the most deprived areas. We've given out how many, there's numbers behind how many packs have been given out and the ages. My concern is, how do we monitor that they've actually used those packs, and why can't we have a dental nurse in schools like we used to? Because at least we identified it more, and we used to train children how to brush teeth, and we identified decay sooner rather than later.
Thank you. So we are following the proportionate universalism in this. So this work covers the wards with dental caries of children of 20% or more, and the number. So according to, we follow the national guidance on supervising toothbrushing scheme. It covers number of schools, and we are looking at expanding that, okay, taking first permission from the national OHID to expand that. My ideal scenario is all our schemes to be supervised scheme, if we can afford it and if we get the permission from the national. In terms of how do we know, I don't think there is a way of knowing, apart from all what we can do is explain to parents and explain to young children and school children on how to use the brush, and then use our dental caries rates as a proxy measure to measure the effectiveness of this. Just to say, dental caries is 100% preventable disease. And in an area with fluoridated water like Dudley, we shouldn't have wards with 20% or more. It should be less than 5%. And that is the aim for us, because toothbrushing is not only toothbrushing, but it's a healthy eating and the brushing. So these are the things which determine and prevent, and visiting a dentist every 6 months. These are the three things that will reduce dental caries of children.
As you know, not many people, well, the rise in decay in children is very, very high. I don't understand why we're putting all the money into doing what you're doing, as you've just explained, and not have a dental nurse in the school where we can prevent a lot of that happening before. We used to have it, it used to work well years ago. And I think it seems like there's a lot of money going into all these tooth packs and people showing them how to do this and that. And when the kids get home, or some parents, not all parents, will adhere to that. But at school, it's monitored. So I don't understand why the education can't be at the school at an early age.
We do have a school nursing, and we do have a health education program, but the inspection, the school inspection program of dental inspection has been stopped long time. I don't know why. So we used to have like a screening for dental screening for children, and that these are national decisions. But we do have school nurses, but they are not dental nurses. They cannot inspect teeth, but they can provide the health promotion and health education information on how to keep teeth.
What I'm trying to explain is that in the long term, think about the savings in the long term of the prevention, because at least you can see that they are brushing their teeth, that when they go in early on in the morning. We used to do it when we were younger. You used to have the tablets that identified decay, and sort of try and encourage the parents, if there is decay, to get them to the dentist before it goes, where they end up losing all the teeth. At least if we could look at prevention is better than, with what we're spending now.
The problem is screening is determined by the screening committee nationally. So I can't set up something for Dudley because it has to be a pathway and it has to link to availability of dentists and others. So in my hand is the promotion and the prevention.
Okay, thank you. Anybody else? Any more questions on the targets? Go to item agenda 9, review of public health grant, pages 46 to 80.
Have a slideshow to be able to put it on the screen. It is an interesting, I think, see if I can put it on the screen. Okay. So I'll take you through the structure of the public health division. So that just give you an idea of the office which looks after all these services. And then the grant itself, the grant has conditions, and I'll take you through the amount of money and where it has been spent. And I'll give you an overview of the public health reserves, and then also an idea on the Healthy Council program, which is areas we fund from other areas in the council. We fund from the public health grant. So this is the department. So if you can see, there is a health protection team and healthcare public health team. That is our NHS facing team. I have a children and an adult and older adult team. And then I have a new team, developing a new team around well-being, financial well-being and partnership. And I have community and healthy places team. And then we have an intelligence team and environmental health trading standards. So in total, it's around 125 whole-time equivalent. So if you remember, public health moved to the council in 2013. So 11 years now being in the council. We receive a ring fence grant annually from the Department of Health and Social Care. We get the notification a bit late, around around February, on our next grant. The grant has to be spent on prescribed and non-prescribed function. People might mistake the terms prescribed and non-prescribed around the statutory and non-statutory, but they are different. A prescribed function means we have to follow a national model of delivery. We can't just make it up for, and these are our prescribed functions are our sexual health checks and health protection and 0 to 5. For example, our health visiting services has to follow a national service specification. Sexual health, there are certain conditions set nationally, and we have to fulfill these conditions. And all other public health services, the rest are non-prescribed, where we will have local flexibility on delivery. We can decide the model we want to deliver. And the public health grant is overseen by OHID, which is Office of Health and Disparity. So inappropriate use of the grant will result in either withdrawal of the grant or having additional control measures on the grant. Basically, like getting commissioners, like Section 114 for the council, it is for the grant. They will take control of how the grant is spent. So if there is an underspend from the grant, we are allowed to keep it and roll it to next year in the reserves. And according to OHID, a reserve between 5% and 30% is acceptable. Anything outside this range is a red flag, and we might be asked why are we having either a too much reserve or too little reserve. And one of our duties is to reduce inequalities in addition to the prescribed and non-prescribed function. So this is the amount of the public health grant in the past 5 years. So starting with around 20 million in 1920, and it is 23,251 for this year. And you can see the variance. The negative means it is an underspend. They underspend each year. We have supplementary grants from OHID around substance misuse. Tobacco grant, we get 400K a year for the coming 4 years. And this grant started to ensure the generation-free, smoke-free, smoke-free work, and also a grant to support additional activities around substance misuse. And this is only 2 years grant. We've also applied to the Sport England, place-based, and we have submitted an application. We're waiting to hear soon, hopefully soon. And we are also applied to access the Commonwealth's Active Communities Grant. And if we are successful, the plan is to start a project in Bensnet and Brockmore to reduce childhood obesity. Beat the street just on Bensnet and Brockmore as a pilot and as a continuation of our efforts to reduce childhood obesity in that ward. This tells you where Dudley is in relation to the payment per head of the population, how the grant is calculated. If you can see, the lowest areas who get per head of the population, they get around 33 pounds per head of population. The highest is just under 200 pounds per head of population. We are slightly above average. So the national average is around 66 to 68. Dudley for this year, we got 70 pounds per head of population. We are, in terms of the Black Country, we are higher than Walsall, but lower than Sandwell and Wolverhampton. And this is usually based on the deprivation level of the area. So I mentioned prescribed and non-prescribed function. So these are the details of our expenditure. You can see, as I mentioned, the prescribed functions, the 4 prescribed functions I mentioned earlier. So in total, we spend around just over 9 million on this prescribed function. The non-prescribed is the rest of our public health activities, the obesity, substance misuse, mental health, and dental health. So these are account to just over 7 million. So in total, 16.7 million of the grant is spent on direct public health function, and that equates to 73% of the total grant. So this graph tells you where we spend, and if you can see, our largest expenditure is on children, the 0 to 19. 42% of the grant goes into the children and to the 0 to 19, followed by our substance misuse services and then sexual health services. So you can see the rank of expenditure. So thought I give you an idea of our contracts. We successfully commissioned all our contracts, and the majority were started in November 2023. And the last one, which is our largest contract, the Not to 19, won by Shropshire Community Trust. And this one started in April this year. So it tells you the contract value and the duration. The majority of our contracts commissioned for 3 years with a possibility to extend it for 2 years and another 2 years. So in total, it is 7 years. If the provider performed well, and if they are happy after 3 years, we'll negotiate. If we are happy to extend the contract, and if they are happy to continue to provide. So that is how it is set. So you can see the number of contracts and the expenditure on each contract. Just to highlight, we have a public health maternity contract, and that is to improve the well-being of women, pregnant women. Smoking cessation during pregnancy, weight management, and vaccination during pregnancy. We don't pay for the vaccine. The vaccine is NHS responsibility, but we improve the uptake. And it's continuous. These are the all our contracts. So I'm not planning to go through them one by one. And these are the contract end dates, just for information. We have a pharmacy public health contract. We have number of services we commission from pharmacies, and these are emergency hormonal contraception and chlamydia screening, and also brief alcohol intervention from pharmacies in the borough. So this is just a pie chart show you the bulk of the distribution and overview of the distribution of the grant, and you can see the bulk is in contracts, followed by salaries, around over 3 million in salaries, and then followed by the Healthy Council program, which I will tell you at the end of this presentation. These are our reserves. So we have committed reserves just over 3.2 million. And then the non-committed reserve, this is our contingency fund, it is 672,000. And then the total reserve is 3.9 million, which is 16.9. Just to point out, our uncommitted reserves is less than the 5% of the OHIT requirement, but because we have a strong, really, health protection team, and our vaccination rates are very high, I am comfortable with that in terms of, and I'm hoping to increase the reserve from any underspend this year to take it to 5%. So any questions so far before we go into the Healthy Council program? Okay, so, yeah, sorry.
So you've got two tables, exactly the same, but the figures don't actually match up.
One of them is 23-24
Yeah.
and 24-25.
No, you're missing a minus sign on one of them. I know it sounds pedantic, but
No, thank you. No, thank you for pointing that out. Which,
minus sign on an article, is it 5?
What page?
1 second. You've got one on page 56 and one on 47. If you put me in front of audit and you had that, they'd maul you.
Page 56, this one.
Yeah, 47. The 2023, 24, you're missing a minus sign on the variance.
The 1.075, it is there.
Yeah, but everything else above it has got a minus sign and 2024 hasn't. The typo, but it is important. Figures are.
23, 24. Yeah, but there is a minus in here.
There's a minus on mine.
There is a minus on
There's no minus on mine.
page
Oh,
40.
47.
Yeah.
Oh,
Okay,
yes,
no,
yes,
thank you.
yes.
Thanks. We will adjust that. Thank you very much.
It's always good to know that we actually read.
Yeah, no, absolutely. Thank you. No, thanks very much. Well spotted. Thank you. So this is really a very important. You might be able to read it in your printed version. This is the model where what we can and cannot fund from the public health grant, and it's a model developed by the associations of directors of public health. So the fully eligible services to be funded from the grant are the prescribed and non-prescribed functions we mentioned earlier. Services that are not eligible are statutory functions of adult social care, children's social care, housing, planning, waste, and then domestic sexual and violence abuse. So these are a no-go area, and it will really generate conditions, additional conditions on grant governance from OHIT. Services which we can fund but not fully fund under specific conditions are leisure centers. So when I show the list of the services we commission, for example, we commission passes for looked after children, gym passes for looked after children. We commission exercises on prescription for a needy high risk population. That's things we can fund, but I cannot fund like a whole gym as a business. That shouldn't be funded from the public health grant. So this is just reiterating the conditions and just showing giving exactly the condition, and these are the screening condition when we get a request to fund something for the local authority. We go through this. So the primary outcome has to be public health and health related outcomes. It shouldn't be a secondary outcome. One of my colleagues, directors of public health, she told me she's been asked to fund, put money on waste. And then she's been told the men who man the bin, they might speak to older ladies and they can reduce loneliness and isolation. And that's not a primary function. Just an example.
I was going to say.
That's a bit convoluted route to as a primary function. So her answer was no. So just to illustrate what do we mean by a primary function, and then also there is a legal duty for us to reference the public health outcomes framework. So when you come to see the list, for example, loneliness and isolation is in the outcomes framework, public health, and this is why we contribute to Pleased to Meet You team, for example. So these are straightforward The program started in 2017 by 700,000 and then expanded, and you will see over 5 million now for this year. Our highest contribution is funding the family safeguarding project. So we paid 1.8 million to start the whole program. I had to get a permission from OHID to do that. And then the family safeguarding project does have substance misuse workers. It does have smoking cessation, and we are also adding referral to weight management and exercise and lifestyle related issues. So each local authority, they calculate the percentage contribution from the grant towards the wider council. And it is used, so the screening question to calculate to include or not to include in the percentage is, if we take public health outside the council, would that service be funded or not? If the answer is no, then it needs to be calculated as part of the percentage. So as a result, if you can see the now our total contribution this year, 24-25, is almost 5.5 million. And you can see the distribution is the overhead. We pay overhead for the services we get, HR and finance and others, around 800 million. Emergency planning, it's a corporate function, but public health pay for it and lead on it. And also the park activator service, it is a corporate function. Flu vaccination for staff, we pay for it as well. We contribute to Armed Forces Covenant Post, Black Country Post, and also we contribute to Forging the Future administration. And then if we add all the switches also, which I'll come to their details, another 2.8 million. So a total program is 4.2 million. And then when we add the one-off spending, these are recurrent spending we pay every year. When we add the one-off spending that, as I said, the family safeguarding, it's spending over 3 years. We're contributing the CCTV cameras and some grant fund licensing and others. So it came all to 5.5, almost 5.5 million from the grant going into corporate this year. And this is a list of the switches. This is the list where the primary outcome is health related. And if you can see, it is not only for like adult and children social care. It covers the regeneration, the planning, environmental health, and I mentioned the leisure, the physical activity for targeted groups and for looked after children. So it is so it is a list. Just to highlight, we do have a memorandum of understanding of each team, and we review the memorandum annually. There are outcomes, so how many children were utilized this service and that, and they provide us with the required data for reassurance. And in case to be ready, if we got audited by OHID, we are ready to provide our governance arrangement of the grant. So this is it. Any question?
Councillor Aston?
No, I think Councillor Kettle.
Sorry, Councillor Kettle.
Sure, thank you very much. Very quickly, thanks, Chair. Thanks, Councillor Kettle. As Mayada has outlined, the incorrect use of the public health grant can have really serious repercussions for local authorities with councils who've tried to pay for their leisure centres and all kinds of weird and wonderful stuff, and they've been men with the public health grant. So I always think it's incumbent on this committee actually to seek assurance at every opportunity that any of our switches, each and every one of our switches, are within the rules and have a demonstrable public health outcome. So I suppose I'll frame it as a question through you, Chair. If the director can confirm that she's confident that all of our switches are within the rules. Also, just on a point of interest, and I always like to benchmark against other local authorities. As far as you're aware, where are we in terms of maybe similar METs in terms of our switches? Are there comparable local authorities who don't switch any money from their public health grant into the general fund? And where are we in terms of the percentage of the public health grant that we are switching? Are we around about average, or are we particularly bad? Thanks, Chair.
Thank you. Thanks. So to answer the question, we are reviewing the first one around governance. We are reviewing all our, we did have our Star Chamber review, and they asked us for reassurance. So we are preparing that, making sure we are in line with OHID conditions. One of the things we added is if there is an underspend in the department, they cannot repurpose it. They have to not return it back to us, but they have to negotiate with us where they want to spend the underspend. So we make sure it is in line with the conditions, the required conditions. In terms of benchmarking, so OHID threshold is again between 20 is a red flag, 20%. 30% is it will invite review, immediate review. Okay, so this is where we are. Birmingham, for example, when they had the commissioners of Section 114, they returned 1 million from the general fund to the public health grant. That reduced their contribution to 13%. So but we are more or less there, similar to Walsall and Sandwell and Wolverhampton.
Okay, Councillor Kettle.
Thank you, Madam Chair. Looking at page 47 to start with, and the shortfalls on the underspend, what happens to the money that is underspent?
It is there, okay. And as I said, there is some of it is committed in projects, committed for 3 years.
Allocated in effect,
Yeah.
not underspent.
Yeah, it is allocated. The uncommitted sum is a 600, only 600 and so the uncommitted is 672. That is my contingency fund if there is any outbreak or any problem, and I can't give that away. I have to keep it.
Yeah. In other words, as Operation sort of Signet found out years ago, we were badly wanting, and when we did have a real problem, I think the whole country realised that it was something that had been overlooked for many years. All right, let's go to page 65, if we may. And as you can see there, there's a pie chart which gives, and they allocated 14.441 million in grants. But if we look at the salaries, the overheads, and whatever other comes to, we're talking about 5.3, nearly 5.4 million in overheads. Just how many people were allocated to distributing this fund? Who took 822,000 in charges, And what does the other represent? The 705,000?
Ian Newman decide the overhead. Ian Newman. So it's corporate decision, the overhead, the 800,000, it's a corporate decision. Okay, in terms of in return of the services public health gets.
In liaison with who?
To finance, so we get support from finance, we get support from HR. Okay, so and the accommodation, the IT systems by using IT. Okay, so that's all we pay for from the grant. As I said, I have 125 full-time equivalent. In terms of heads, it's higher because I have job shares as well. So in terms of persons,
So you're saying that you have 125 employees working on the distribution of these funds?
No, on the whole public health department.
In the total?
Yeah, in the whole time equivalent. In number of employees is higher. It's around between 140 and 150 people.
Well, don't you agree, Mayada, that 5.38 million in very vague attributions of, and when you look at the figure that we actually allocated, don't you agree that 703,000 other on top of corporate and overhead internal charges? I mean, that's fancy money. That's £1.5 million straight away. On top of that, we have the salaries, nearly 4 million. Surely it didn't take £4 million to distribute this money in wages? Surely.
As I said, it is, as I said, in terms of 125 full-time equivalent. We, the majority, we follow the council pay grade. So, and this is what I got from my finance.
Could we ask for a breakdown of these figures, and will you send them to the whole of the committee, please?
Yeah, I can't send you by person. I can't send you. I can send you how much are we spending on the consultant level, on because of the information governance.
I'm finding it very, very hard to swallow. I must admit. We're talking nearly 6 million quid.
The salaries are 3.8 million.
No, that's only the start of it. You got 3.8 on salaries. You got the overhead and internal charges with 822,100, and on top of that, this nondescript other is 703,000.
I can send you the details of the others. Okay. And I can send you a breakdown of salaries, but I have to consult with our information governance to see, because I can't give you.
You've got to give me everything I asked for.
Okay, but I'll consult.
No, you've got to give me everything I asked for. If I ask for a breakdown of these figures, I need them, please.
Within the information governance rules, yes.
Okay, Councillor Kettle, the request has been noted.
I think there's a principle here that
yes.
Elected members,
I agree,
must be given all information appertaining to enable us to do our job properly, and nothing can be withheld. That's my understanding.
Okay, Councillor Madare. Director, sorry.
It depends on, because if there is confidentiality issues, and if there are, for example, if we are talking about patients and unidentifiable information, we can't release that. There are information to release. I'm not talking about this one. You have to go to court to get that information. But this is why I need to consult with my information governance, okay, to see if I need to send you identifiable information, for example, the head of health protection, we all know who is he. Okay, so if I send you his salary, am I allowed to do that or not?
I have gone to the chief executive, going back, I think before John Polly, and this very principle of what we can and what we cannot have. And the understanding I've had for many years through all our chief executives, that if an elected member asks for information appertaining to the job and that allows them to do the job properly, that information cannot be denied them. Check for me by all means. I know you're new in your new position. I don't wish to give you a hard time, but I think on a matter of principle, we must allow this to happen. And if the information is available, could we please have it?
Okay, if the information is available and if I'm allowed to share it, I will share it.
Not the word allowed. Not the word allowed. Go to higher authority if you wish.
I have to
By all
protect my staff.
Yep.
And I have to follow the rules. So I'll make sure I am following the rules. Okay.
By all means.
Councillor Collins?
Just a thought, I think, Mayada, what you're describing to us is commonly known as best practice now, isn't it? And rules have come a very long way in terms of what can be shared and not. It may be, Chair, through you, that it might be appropriate if that information can be shared, for it to be shared on blue paper if you feel that it's sensitive. At least then members would have access to that, but it wouldn't be shared widely beyond this committee. Just an idea.
I agree. I agree.
It's actually available on the internet. There's an Excel document with anybody above, I think it's £52,000 salary. It's actually available for every department in the council.
In names, by name?
Not names, it's got positions.
Yeah, okay.
And it's got the gradings of those positions as well.
Okay,
Okay?
so thank you. So, and then anyone under 50? Okay.
Anybody else? Right, now we'll go on to agenda item. Is it 9? 10, sorry, progress tracker and future business, pages 81 to 82.
Sorry.
Thank you, Chair. Yes, so this is the progress tracker and future business. That's just for noting. If anybody has anything to add.
Noted.
Chair, I'm very conscious that on page 81 it says that Dudley Integrated Health and Care NHS Trust be requested to report on the High Oak surgery to a future meeting of the committee. Whilst that's been done today, I do think that the ward members are at least entitled to a little more up-to-date and sooner information in terms of what's going on for their residents so they can feed it back, and certainly before our next meeting on the 5th of December. So I request respectfully that DHC, as soon as they, DGNHS, as soon as they have that information, could circulate that to the wider committee and with particular attention to the ward members, because I'm quite aware that 2 of the ward members don't sit on this committee.
Madea?
We'll take that on board. Thank you. You can see my diary now.
Right now.
Oh my God. I'm from one hall to another.
Right, agenda item, just before we go, 11, Household Support Fund. Any update for us and any data?
We've sent you a written response on, and the plan is once we finalize the Household Support Fund 6 payment plan, we will invite all members to a meeting to take them through the review of Household Support Fund 5 and then the plan for the 6.
Open to questions. Councillor Aston?
Apology for leaving it so late. Just to make my question under council 11 point. And thank you for whoever put this together. Very much appreciated. Just felt pertinent given the fact that they ended. And as councillors, we do get a lot of questions and queries regarding the household support fund. So I welcome the commitment that a briefing session for all members of the council is imminent. Thank you.
Thank you. Thanks, Councillor Adam.
Thanks, Chair.
Councillor?
Yeah, thanks, Chair. Could I just request that meeting possibly could be done like a scrutiny at night for us members that work, because obviously we can't get there in the day, and it is a vitally important meeting that we should be at.
Absolutely. We'll aim for a 6 meeting, 6 o'clock.
It's all right. There's a lot of programmes and a lot of briefings that happen in the day. Pet hate of mine, and I keep raising it, but a lot of us do work, and we need, important ones like this needs to be scheduled at times when we can all attend.
Okay, thank you. And it's going to be a Teams meeting, so people can attend. Yeah.
Right, I'll call this meeting to a close and thank you for all your contributions. Good night.
Thank you.
Good night.